मैम स्टार्ट करें क्या? हेलो। हेलो। मैम अनम्यूट कर लीजिए, म्यूट है।
हेलो।
हेलो।
हाँ,
मैम
आवाज
स्टार्ट
आ
कर
रही
देते
है?
हैं। जी जी जी, आवाज क्लियर आ रही है।
ठीक है, मेरी आवाज आ रही है आपको?
जी जी मैडम, आवाज आ रही है।
ठीक है, बस मैं स्टार्ट कर दूं?
जी मैडम, स्टार्ट कर देते हैं। 50 स्टूडेंट्स तो हो गए।
ठीक है।
ओके मैडम।
Okay, Assalamu alaikum. I'm Dr. Aisha Salim, and today I will be talking about pneumonia in children. Okay, this is the outline of my talk. First of all, we will briefly discuss the definition of pneumonia, and then the epidemiology, etiology, its pathogenesis, what are the ways to diagnose pneumonias, the treatment options, the complications which can occur if it is not timely treated, and how it can be prevented, and then the prognosis of the disease, followed by just few questions which I will ask from you. Okay, now what is the definition of pneumonia? Pneumonia, as we all know, that is the inflammation of the parenchyma of the lungs, right? So as far as the epidemiology is concerned, pneumonia is the second most common cause of morbidity and mortality in children throughout the world. So we can see that a lot of children are affected from this disease worldwide. With approximately 158 million episodes of pneumonia per year, we can see that 154 million are occurring in developing countries, which is a huge number. And this is estimated to cause around 3 million deaths, or an estimated 29% of all deaths among children under the age of 5 years throughout the world. So it's a big number. It's really a serious problem for children. Okay, this is very important slide, which is showing the etiological agents in different age groups. We can see that in the neonatal age group, especially in the neonates who are less than 3 weeks of age, group B Streptococcus and E. coli are the most common organisms which cause pneumonia. And this is followed by Streptococcus pneumonia and H. influenza. So bacterial pneumonias are more common in this age group. Now, from 3 weeks to 3 months, and also from 4 months to 4 years, we can see that viral pneumonias predominate. They are more common. And the organisms, viral organisms, include respiratory syncytial virus and other viruses like parainfluenza, influenza, and adenoviruses. Then there is also chance of bacterial pneumonia, but more common, the organisms are viral. And after the 5 years, again, the bacterial pneumonias predominate. And in immunocompromised patients, we can see that any organism like fungal infections, bacterial infections, pneumocystitis, or even the mycobacterium, they can all cause atypical organisms. So any opportunistic organism, any viral, bacterial, fungal infections can occur in those patients who are immunocompromised. Okay, now what is the pathogenesis of pneumonia? The normal physiology of the respiratory tract is that it is kept sterile by physiologic defense mechanisms, and these include mucociliary clearance, the properties of the normal secretions such as secretory IgA, and clearing of the airway by coughing. So these are the normal protective mechanisms with the help of which the airway is kept sterile. Now, what happens when any organism attacks the respiratory tract? There are different ways of injury organisms cause injury to the epithelium of the respiratory tract. Like viral pneumonias usually result from a spread of infection along the airways, and this is accompanied by direct injury of the respiratory epithelium, and it results in airway obstruction, abnormal or excessive secretions, and cellular debris. So when there is more secretions, the airway become obstructed, right? On the other hand, Streptococcus pneumonia produces local edema, and that aid in proliferation of organisms resulting in characteristic focal lobar pneumonia. So viral pneumonias are usually, they are diffuse, they cause diffuse injury, and they will be bilateral infiltrates if we see the X-rays. On the other hand, Streptococcus pneumonia usually cause lobar pneumonia. Group A Streptococcus infection, again, it causes more diffuse infection of the respiratory tract. And Staph aureus, on the other hand, it manifests in confluent bronchopneumonia, which is often unilateral, and it is characterized by the presence of extensive areas of necrosis and cavitation, which result in nematoceles, or maybe there may be pus formation, which is called lymphaema, when there is fluid and fluid becomes infected and pussy, or at times there may be bronchopulmonary fistulas. Now, what are the clinical manifestations? How the children with pneumonia present to OPD or emergency department? Fever is a sign of inflammation. So whenever there is inflammation, there will be fever. And specific symptoms related to respiratory tract will include cough. Cough can occur in both upper and lower respiratory tract infections. There may be grunting. This is due to the obstruction caused by the secretions, especially of the obstruction of the upper airway. Due to increased respiratory rate, there may be signs of respiratory distress, which include nasal flaring. The child may become restless and irritable. There may be tachypnea or increased respiratory rate. There may be tachycardia because of the fever also, and because of the infection also, the heart rate will rise. There may be respiratory distress, and this can be observed with not only nasal flaring, but also with supraesternal recessions, subcostal recessions, intercostal recessions, and in later stages, when the child is going towards respiratory failure, we may notice cyanosis, which is usually central, and respiratory fatigue. There will be gasping pattern of breathing. Ultimately, the child will require ventilatory support, and there may be signs of congestive cardiac failure, like there may be periorbital or pedal edema. There may be hepatomegaly, along with coarse crepitations all over the chest. There may be basal crepitations indicating that the child is going into congestive cardiac failure. So these are the signs and symptoms or clinical manifestations in pneumonia. What are the auscultatory findings? These were the signs and symptoms which I have just mentioned. The auscultatory findings include crackles. Crackles are bubbling sounds which are heard with the help of a stethoscope. And the wheezes are the whistling sounds which are produced by narrowing of the airways. So we can appreciate crackles and wheezing both in cases of pneumonia on auscultation. There may be diminished breath sound if it is, for example, lobar pneumonia. So on the affected area, the breath sounds will be diminished. And on the same area, there will be dullness on percussion. There may be bronchial breathing. And I think you all know the difference between the vesicular breathing and breathing. The vesicular breathing is basically heard over the thorax, and we know that it is low-pitched and softer than bronchial breathing. And in vesicular breathing, the expiration is shorter, and there is no pause between inspiration and expiration. And the intensity of the breath sound is higher in bases in erect posture and in dependent lung in deep cubitus position. So this was vesicular breathing. Now what happens in bronchial breathing? Basically, it is higher pitched and louder. And in bronchial breathing, inspiration and expiration are equal. They become equal, and there is a pause between inspiration and expiration. Okay? And it can be heard over the thorax. So this is the difference. Vesicular breathing में क्या था कि expiration shorter थी, and there is no pause between inspiration and expiration. And in bronchial breathing, there is a pause between inspiration and expiration, and both are equal. Okay. So how we diagnose pneumonia? First of all, the chest X-ray gives us a lot of information. It not only tells us the areas of involved, but for example, whether it is bronchopneumonia, lobar pneumonia, or it is associated with complications like pleural effusion or sometimes pneumothorax. We can get a lot of information on X-ray. CBC and differentials are very important because in the CBC, we can have an idea about the etiological agent. There is neutrophilia when there is bacterial infection, and there is lymphocyte predominance when there are viral pneumonias. CRP and ESR are acute phase reactants, and they are increased in inflammatory conditions. Blood culture helps us again in finding out the etiological agent. Culture of the sputum, if usually children don't produce sputum, but if they do produce, So we can send the culture of the sputum also in order to find out the organism, especially in cases of tuberculosis. And when the child develops complication like pleural fluid, so we can tap the fluid and send it for detailed report, gram staining, culture, and acid-fast bacilli staining. ASOT titer is sent in the blood if the suspected organism is Streptococcus. Ultrasound test helps us in finding out the complications. Sometimes there is mild pleural effusion, sometimes moderate, so we can grade the amount of pleural effusion with the help of an ultrasound test. And workup of TB is sometimes required, especially in unvaccinated children or when there is history of TB contact. So we do workup for tuberculosis, which include not only the culture of the sputum and acid-fast bacilli, but also the Montauk's test, right? Now, this is the example I'm showing the X-ray AP view, which is showing that there is extensive involvement of the right lung. We can see homogeneous upper, middle, and half of the lower lobe of the right side of the lung. And trachea is central, okay? And the angles of the diaphragm are clear on both sides. So this is lobar pneumonia of the right side involving the upper, middle, and half of the lower lobe. Next is again the picture of X-ray of lobar pneumonia, which is involving the middle and lower lobe of the right side. Okay. This is lobar pneumonia, which is involving the upper and middle lobe of the right side. This is the example of bronchopneumonia. We can see bilateral infiltrates. Okay, dono sides we can appreciate bilateral infiltrates. And in these X-rays, there were no complications like pleural effusion or pneumothorax. The trachea is central, but there are findings suggestive of pneumonias. Now we have to decide which are the children who need to be hospitalized and which are the children which can be treated on oral basis on oral antibiotics, right? So these are few indications for admission. For example, if the baby's age is less than 6 months, we have to admit the patient. And the reason is that younger the baby, there will be more chances that the parents can miss the danger signs and the child's condition can deteriorate quickly. And the child is too young to tell anything about his or her condition. So it's better to admit the patient for close monitoring and also for monitoring of the complications. Then if there is involvement of the multiple lobes, so there are more chances that the child can deteriorate at any time and may need ventilatory support. So this child needs close observation and admission. When there are signs of respiratory distress, for example, if the child is having increased respiratory rate, he's becoming tachypneic, tachycardic, nasal flaring, subcostal recessions, then it will not be, the child will not be able to take feed properly. So we have to admit the patient on, maintain IV line and give proper fluids. Manage. The child needs supplemental oxygen. The child needs admission. Now, why there is dehydration? Why there is dehydration in cases of pneumonia? As I have just mentioned, when there are signs of respiratory distress, the baby, it's very difficult for the baby to take feed properly, and as a result, the child becomes dehydrated. Secondly, when there is fever, when there is increased respiratory rate, there is more insensible water loss from the body. And this also adds on, making the child dehydrated. Then we have to give proper fluid, right? When there is vomiting and the child is unable to take oral feeds, so this is also an indication for admission. When there is no response for oral antibiotics, this means now we have to put the child on IV antibiotics. Immunocompromised state, for example, children with cystic fibrosis or malnourished children, there are more chances of developing complications in these children. So they need close monitoring and admission. Sickle cell anemia with acute cell syndrome. Now, what happens in sickle cell anemia? There is involvement of the chest with or without clinical signs of distress of respiratory system. So these children also need close monitoring and observation in the hospital, and we admit these children. So this is a list of patients who need admission. Okay, now as far as the treatment of pneumonia is concerned, basically treatment of suspected bacterial pneumonia is based on presumptive cause and age and clinical appearance of the child. And we start with first-line antibiotics if there is no pre-existing resistance in the communities. We all know that there is malpractice going on, and without indication, some practitioners prescribe antibiotics, and this results in resistance to the organism. So if there is no first-line resistance, then we can start with first-line. Otherwise, we can change the antibiotic according to the culture and sensitivity of the organism. Now, sick children who need hospitalization, they need both supportive and specific management. And what do we mean by supportive and specific? Supportive treatment means the child needs oxygen and IV fluids in order to maintain the metabolic rate of the body, antibiotics if there is fever, and sometimes we do prescribe steroids when there is wheezing, and in order to control the inflammation. And a specific treatment means the antibiotics, especially according to the culture and sensitivity. So we start with first line, and then we can change the antibiotic if it's not working after the blood culture report. Now, what is the role of zinc in pneumonia? So there are a lot of studies going on, and they show that zinc is very helpful in reepithelialization of the respiratory tract, just as it does in reepithelialization of the gut in cases of diarrhea. So it's very beneficial. So it reduces all respiratory tract diseases, and there is a 2.5-fold decrease in the respiratory tract infection when zinc is added as a supplement during the illness, and reduction of 45% incidence of the lower respiratory tract infection with the help of zinc. So one should add zinc supplements whenever we are treating children with pneumonia. Okay, now role of vitamin A. Vitamin A supplementation has been found to reduce morbidity and mortality of severe respiratory tract infection associated with measles. We know that measles is a very deadly infection. And in our part of the world where children are malnourished, and when they acquire measles, they become more malnourished as a complication of measles, and their immunity decreases, and they develop a lot of complications post-measles. So vitamin A reduces the morbidity and mortality in children who develop pneumonia, especially after infection like measles. And there is different dose, like under 6 months, we give 50 international units, 50,000 international units, I'm sorry. And 1 year, 1 lakh international units. And after 2 years, the dose of vitamin A is 2 lakh international units, which is given on day 1 and day 2. Now, vaccination is very, very important. We know that the vaccine, pneumococcal vaccine, is given at 6, 10, and 14 weeks. So in US, it was found that mortality caused by pneumonia in children declined by 97% with the help of vaccination. And it is hypothesized that this decline was attributable to introduction of vaccine. So unfortunately, a lot of children in our part of the world are partially vaccinated or unvaccinated. So we can see that it is a vaccine preventable disease. So if they give vaccine, there are a lot of chances that this disease can be prevented, right? So pneumococcal vaccine should be given to all the children according to the EPI program. Now, there are certain risk factors for acquiring pneumonia in children. For example, lack of breastfeeding is a big risk factor. For example, if the child, we know that breast milk contains immunoglobulins, which helps in boosting the immunity of the child. So if the child is not on breast milk, he is not getting sufficient amount of immunoglobulin from the formula milk, and he or she is at risk of having pneumonia. Secondly, bottle feeding with bad hygiene. This also increases the risk of upper and lower respiratory tract infections along with diarrhea. So lack of breastfeeding is a huge risk factor. Again, the parental education, the same thing. If they don't know how to clean the bottle and maintain the hygiene of the child overall, so the child is at risk of acquiring any infection, not only pneumonia, but any infection like fecal-oral routes like hepatitis and typhoid and diarrheas along with pneumonia. Poor socioeconomic condition because of the bad hygiene is a risk factor. Low birth weight is a risk factor because the immunity of these babies is low, and they are at risk of developing pneumonias more as compared to the normal or good weight babies. Immunosuppression, for example, if the child is suffering from any immunodeficiency or any chronic illness in which the immunity has decreased, so he or she is at risk of developing respiratory tract infections like pneumonias. Chronic respiratory illnesses like cystic fibrosis, tuberculosis, they are the risk factors for developing pneumonias, and malnutrition itself is an immunocompromised state, and these children are at risk of developing pneumonia more than the children who are well nourished. Now, what are the complications which can occur due to pneumonias? So we can see that pneumonia can complication due to direct spread of bacterial infection or due to the hematological spread. Whenever there is direct spread of infection, it can lead to pleural effusion, that is the fluid in the pleural cavity. Empyema, when this fluid becomes infected and pussy, this is called empyema, and there may be inflammation of the pericardium, which can lead to pericarditis. These are very, very serious complications which can occur due to direct spread of bacteria from the lungs to these areas. Hematological spread of the organism can lead to meningitis, osteomyelitis, and sometimes arthritis. So it can be, very dangerous, especially meningitis. Now this is the X-ray which is showing right-sided pleural effusion. You can see homogeneous opacity, and we can also see shifting of the mediastinum and the trachea. This is trachea. Normally the trachea is slightly on the right side, right? This is the normal position of the trachea, but we can see here the trachea has been shifted towards the left side, right? So the fluid in the pleural cavity is pushing the trachea and the mediastinum and the heart towards the left side. So this is the picture of right-sided pleural effusion, which is involving whole of the right lung. Okay, now how we differentiate between the transudate and empyema. Okay? Whenever there is pleural effusion, it has to be drained with the help of a chest tube, or sometimes in emergency situation, we do a tap with the help of a syringe. So whenever if the fluid is drained, it is sent for DR and culture. Okay? So the difference between transudate and exudate is that the appearance of the transudate is clear. On the other hand, as empyema is purulent, so its color is cloudy, right? Or yellowish, you can say. And the cell count per cubic millimeter in cases of transudate is less than 1,000 per cubic millimeter, but it is often more than 50,000 because it is caused by bacterial infection. So the cell count will be very high in cases of empyema. There will be lymphocyte or monocyte predominance in case of transudate. On the other hand, there will be neutrophil predominant or neutrophilia in cases of empyema. Lactate dehydrogenase will be less than 200 units per liter in cases of transudate, and it will be more than 1,000 units per liter in case of exudate. Then we send pleural fluid serum LDH ratio, and it is less than 0.6 in cases of transudate, and it's more than 0.6 in case of empyema. Protein is, the level of protein is more than 3 in cases of empyema. Usually it is less than 3 in cases of transudate. Pleural fluid protein will be less than 0.5 in case of transudate, and it will be more than 0.5 in case of empyema. Glucose will be low in cases of empyema. It will be normal in cases of transudate. pH will be acidic in case of empyema, and it will be normal to alkaline in case of transudate. Gram staining is usually negative in cases of transudate, but in about less than 1/3 of the cases, gram staining is positive in cases of exudate. So this is very important to know the difference between empyema and the transudate, right? Okay, we can also send culture of this fluid or gram staining I have mentioned, and इसके अलावा जो है tuberculosis की workup कर सकते हैं, ठीक है? Okay. Now, what is the prognosis of pneumonia? Mortality with community-acquired pneumonia in developed nation is very rare because of the vaccination, because of the good hygienic conditions. So the mortality is very rare in developed countries. But on the other hand, in developing countries, the prognosis depends not only the causative organism, but also the associated risk factors. As we have already seen, there are a lot of risk factors in our part of the world. The children are malnourished, there is lack of breastfeeding, lack of parental education, lack of vaccination. So these are the things which make the disease worse. So in our part of the world, the prognosis sometimes is not good. Okay, now the questions. If you can recall, you can answer. I mentioned in my beginning of the talk that the most common organism causing pneumonia in neonatal age group is, can anyone answer? Streptococcus pneumoniae, E. coli, group B Streptococcus, group A Streptococcus, or Haemophilus influenza? Yeah, group B Streptococcus is the correct answer. This one, answer C. Okay, so this is the most common organism in neonatal age group. Okay, on examination, the percussion note will be stony dull in which condition? Lobar pneumonia, bronchopneumonia, pleural effusion, pneumothorax, or foreign body aspiration. Yes, anyone, please? In which condition the percussion note will be stony dull? It's not dull, but it's stony dull only. And out of these, anyone? Yes, it's not difficult. We have already discussed the auscultatory findings. I've mentioned there will be crackles, there will be wheeze, there will be dullness on percussion, there will be diminished breath sounds. So which condition leads to stony dull percussion note? Anyone? Any idea? No? Okay, the answer is C, pleural effusion. The percussion note will be stony dull in case of pleural effusion. Challenge ye bataiye, I showed this X-ray previously. What this X-ray is showing? So out of 82 students, none of you is able to answer the question. Yes, it is pneumonia, but what type of pneumonia it is? It is bronchopneumonia, is it lobar pneumonia, you know, or which? The lobar pneumonia, yes. And now you can tell me which lobes are involved. Lobar pneumonia of the left side or the right side, upper lobe, middle lobe, lower lobe, which lobes are? You can see the homogeneous opacity on the right side, which is involving the right upper, middle, and part of the lower lobe also. Yes. Okay. What is this? X-ray chest, AP view, which is showing what? I just showed this X-ray few slides back. Anyone? This is, yes, pleural effusion, which is involving whole of the right side of the chest, right? And this is also causing shifting of the trachea towards the left side, and also a little bit, you know, the heart shadow is not visible on the right side, right? Because of the effusion. Heart has also been pushed slightly towards the left side, more left side, and this is the trachea which has been shifted, right? So this is the X-ray of pleural effusion, right-sided pleural effusion involving whole of the right lung. Okay, if you have any questions, you can ask. Yes, any questions? I think I'm very, this is the one thing which you should all remember. Okay? The difference between transudate and exudate, it's very important slide. The complications, you all should know what are the complications which can occur due to direct spread and the hematological spread of the pneumonia. LDH is an inflammatory marker basically, and it becomes very high in cases of bacterial infections. So it's an inflammatory marker just like C-reactive protein and ESR, right? Erythrocyte sedimentation rate, all right? Risk factors one should know, especially in our part of the world. It's very, very important to know the risk factors. While you take history, you should, take these risk factors into consideration. All right, vaccination, lack of vaccination is a big risk factor. Vitamin A supplementation, zinc, they have protective role. Not only they are reducing the incidence of pneumonias, but also they also decrease the duration of a stay in the hospital, right? So patient recover quickly when they get these supplementations. Who need hospitalization? This is also very important to know. Who is the child who needs hospital treatment, and who is the child who can be sent home on oral antibiotic therapy. And whenever we send home, we tell the parents the danger signs, right? General danger signs. And what are those danger signs? We tell the parents to look for the nasal flaring, subcostal, intercostal recessions. If there is difficulty in feeding, right? Then you have to bring the child to the hospital if the child is not taking feed properly. Okay, these were the X-ray and diagnostic modalities which help in making the diagnosis. And these were done here. The difference between bronchial and vesicular breathing is very important. Okay, these are the clinical manifestations, and that's it. I think, thank you very much. If you don't have any questions, then we can sign off. Does the treatment stay the same if the patient only one lung? I don't understand the question. Does the treatment stay the same if the patient only on one lung? What do you mean by this, one lung? You mean the child is, the one lung is involved because of the pneumonia and the other lung is healthy? Yes, you can. The patient can, the treatment of the patient depend. We cannot outline same patient for every patient, same treatment for every patient. Treatment depends on the child's clinical status. Some patients need oxygen support only, need respiratory support. So it all depends on the clinical status of the patient. When the whole lung is involved, obviously there will be respiratory compromise. So this patient may, for example, if there is massive pleural effusion on one side, then we have to go for the surgical intervention, like we have to pass the chest tube in order to drain the fluid. This fluid will not be, just treated with the help of an antibiotic. We have to drain the fluid with the help of chest tube, and then we send the investigations on that pleural fluid to find out whether it is transudate, exudate, or the causative organism. Then we have to, switch the antibiotics according to the culture and sensitivity. So it requires a lot of, teamwork and different treatment options. Anything else? Crackles and wheeze are different by stage. Yeah, crackles, I mentioned, that are the bubbling sound, and they are produced whenever there is fluid in the lung parenchyma. ठीक है, consolidation के cases में आपको crackles मिलते हैं, just like bubbling sound. Wheeze, on the other hand, is the narrowing, whistling sound. Whistling sounds which are produced when there is narrowing of the airway, and when the air passes through these narrow airways, it produces sound like whistling. So wheeze is whistling sound. Crackles are bubbling sounds, and both are audible with the help of a stethoscope. Ji, any other question? If no, then we can sign off. Are double or single lumen endotracheal tubes used in severely affected patients? We use single lumen endotracheal tubes. Single lumen endotracheal tubes which are cuffed and non-cuffed, right? That's it? Okay. Okay, thanks everyone.
मैम एंड करनी क्लास?
जी जी